Good afternoon, everyone. Myself, Dr. Saeed Vaivora, working as Assistant Professor in Cardiac Anesthesia at Unmicrc Institute of Cardiology and Research Center. Today, our seminar on mechanical ventilation. We will be covering the brief history and the physiology, the phase variables of the mechanical breath, basic modes of mechanical ventilation, not all modes, just the basic modes of mechanical ventilation, monitoring of the respiratory mechanics, desynchrony of the patient and the ventilator, indications of mechanical ventilation, weaning from the mechanical ventilation, and the hemodynamic effects. The last 4 to 5 topics are more of a clinical aspect of a mechanical ventilation. Now, talking of the history, initially the mechanical ventilation was started as a negative pressure mechanical ventilation. They were called as iron lungs. In 1928, they were first used in Boston Children's Hospital, and they were widely used during the polio epidemic of 1940 and 50. Later on, mechanical ventilation was shifted to positive pressure mechanical ventilation, and it has now become a modern standard of mechanical ventilation. Now, coming to the basic lung physiology, transpulmonary pressure is equal to the pre-alveolar pressure minus the pleural pressure. Transpulmonary pressure is equal and opposite to the lung elastic recoil pressure for a given lung volume. To increase the transpulmonary pressure, either you need to increase the pre-alveolar pressure during the positive pressure ventilation or decrease of pleural pressure which occurs during the spontaneous breathing. There is a curvilinear relationship between the transpulmonary pressure and the lung volume. Transpulmonary pressure determines the lung volume. This graph shows the curvilinear relationship between the lung volume and the transpulmonary pressure, and the transpulmonary pressure is the difference of the alveolar pressure minus the pleural pressure. Now, these are the sequence of events which occurs during the spontaneous ventilation and the events which occurs during the positive pressure ventilation. In both, there has to be increase in transpulmonary pressure, but during spontaneous ventilation, the transpulmonary pressure increases by decrease in pleural pressure, and in positive pressure ventilation, that is mechanical ventilation, transpulmonary pressure increases by increase in alveolar pressure. Now, each mechanical breath can be divided into a phase variables. These are trigger, target, cycle, and the baseline. Trigger determines when the expiration ends and inspiration begins. Target determines how the flow will be delivered during the inspiration. Cycle determines when the inspiration will end and when the expiration to begin with. Baseline is the proximal airway pressure during the expiration. Now, this figure, this is a trigger which initiates the inspiration. Target dictates how the tidal volume is being delivered. Cycle is the termination of inspiration and beginning of expiration, and baseline is the proximal airway pressure during the expiration. Now, trigger. The trigger basically is of 3 types: patient trigger, ventilator trigger which guides the controlled breath, and there is a assist control trigger which is a hybrid trigger, which is the combination of patient trigger and the ventilator trigger. Patient trigger can be further divided into pressure trigger or the flow trigger. Pressure trigger is the amount of negative pressure the patient has to apply to trigger the ventilator for a breath. It can be set as minus 1 cm of H2O to minus 5 cm of H2O. Flow trigger is the amount of decrease in flow in the expirated lead, can be set to 1 to 5 liter per minute. Now, ventilator trigger is a time trigger. If the respiratory rate you have set on ventilator is 12 per minute, then at every 5 seconds a breath will be delivered. And assist control is a hybrid trigger which is a combination of patient trigger and the ventilator trigger. Now, these are the pressure trigger and the flow trigger. There is a continuous flow of gas from the inspiratory limb to the expiratory limb. If you set a flow trigger of 3 liter per minute, then the patient has to suck in a gas equal to 3 liter per minute of gas to initiate a breath from a mechanical ventilation. Pressure time curve. Now, target. Target is the most misunderstood variable. The flow, which is volume delivered per unit time, and pressure are the target variables. This means flow and pressure are the target variables and not the tidal volume. Flow can be depicted as difference of proximal airway pressure and the alveolar pressure upon the resistance. Here the flow is an independent variable set by the operator and it is achieved by the ventilator. Flow or pressure can be set as a target variable, but both can't be set at the same time. Flow waveforms are of 2 types: constant flow waveform, which is a square wave waveform, and decelerating ramp waveform. Pressure targeted modes like pressure control ventilation typically produce decelerating ramp as the flow quickly rises to achieve the set proximal airway pressure, and then it gradually decreases as the alveolar pressure rises. Now this is the flow targeted modes and this is a pressure targeted modes. In flow targeted modes like in volume control ventilation, the flow waveform can be of square wave or it can be decelerating ramp, and in pressure targeted modes like in pressure control ventilation, flow waveforms are decelerating ramp waveforms. Now these are the how the mechanical ventilation will behave in flow targeted modes like in volume control ventilation, and in pressure targeted modes as in pressure control ventilation with biting of endotracheal tube. If the patient bites the endotracheal tube, then there will be rise in the resistance. Now as in flow targeted modes, flow remains constant. So with increase in resistance due to biting of endotracheal tube, proximal airway pressure rises. Whereas in pressure control ventilation, with increase in resistance, as the proximal airway pressure remains constant, the tidal volume decreases. Now if the patient initiates breath, patient has a sustained inspiratory effort, then there will be decrease in alveolar pressure. So with volume control ventilation, the flow remains constant, so the proximal airway pressure decreases. But in pressure control ventilation, with decrease in alveolar pressure due to inspiratory effort, the tidal volume or the flow increases. Hence, in pressure control ventilation, tidal volume needs to be observed very carefully. Now this is a cycle variable determines when to terminate the inspiration by using the time, volume or flow as a variable. So a breath can be a time cycle breath, it can be a flow cycle breath, it can be a volume cycle breath, or it can be a pressure cycle breath. Now flow cycle breath, you can see when you can set the flow cycle as a 25% of the peak inspiratory flow. When the flow reaches 25% of the peak inspiratory flow, inspiration terminates into expiration. Baseline, it is a proximal airway pressure during the expiratory phase. You can set it as a 0 or you can set it at some positive value. If it is 0 and expiratory pressure, then there will be complete recoil of the lungs and proximal airway pressure equals the atmospheric pressure at the end of the expiration. If you have set the PEEP, then at the end of the expiration, proximal airway pressure remains above the atmospheric pressure at the end of the expiration. Basic modes of ventilation. These are the three basic modes determined by the phase variables. From these three basic modes, we have many other modes which are covered separately in a different seminar. Volume control ventilation, pressure control ventilation, and pressure support ventilation. Now in volume control ventilation, the trigger is the assist control, which is a hybrid trigger. So there will be a patient assist trigger and a ventilator control trigger. Now target variable in volume control ventilation is a flow. Flow waveform can be set as a constant flow waveform or it can be set as a decelerating ramp flow waveform. Cycle variable is a volume. Now the T inspiratory time will be determined by the ventilator and it cannot be altered by the patient respiratory mechanics, that is resistance or compliance, or the patient's inspiratory efforts. Now you can see the decelerating ramp flow waveform in volume control ventilation and the constant flow waveform in the volume control ventilation. The pressure waveform in volume control ventilation is determined by the result of interaction between the set variables, that is flow and volume, and the respiratory system, that is the resistance and compliance. So the pressure waveform becomes dependent on the flow waveform, how you set the flow waveform. Pressure control ventilation, the trigger is assist control again, which is a hybrid trigger. Then there is a target is the pressure. Whenever you say pressure, it is the proximal airway pressure. Now so the cycle is a time. Time is T inspiratory time is set on the ventilator. Inspiratory time cannot be altered by change in respiratory mechanics, there is the resistance or compliance or the patient's respiratory efforts like in volume control ventilation. Pressure support ventilation. The trigger here is only assist trigger, that is all the breaths are initiated by the patient. The target is a proximal airway pressure and it generates a decelerating ramp flow waveform like pressure control ventilation because it is a pressure targeted mode. The cycle is a flow cycle. Volume terminates, ventilator terminates the inspiration once the inspiratory flow reaches the set percentage of the flow, that is 25% if you are set. Inspiratory time in pressure support ventilation can vary from breath to breath and patient can regulate the inspiratory time by adjusting the respiratory efforts, thus resulting in better patient ventilator synchrony. This is a basic summary of the modes of the ventilation. Now Coming to the monitoring the respiratory mechanics, a ventilator is not only the therapeutic tool, but it can give a lot of information about the patient's respiratory system and can serve as a diagnostic tool for the respiratory failure of the patient. The respiratory system of the patient can be divided into the two components, resistive component and the elastic component. The resistive component, and hence the proximal airway pressure becomes sum of pressure due to resistive component and pressure due to elastic component. The resistive component can be defined as flow into resistance, and elastic component, which is due to the lung parenchyma and chest wall, can be defined as volume by compliance. Compliance, which is the stretchiness of the lung, is a reciprocal of the elastance, which determines the stiffness of the lungs. Now, peak versus plateau pressure on the ventilator. To determine the plateau pressure, you can have an inspiratory pause maneuver. By doing the inspiratory pause, the expiratory valve closes at the end of the inspiration, and so the pressure across the respiratory system equalizes, resulting in no flow. So the resistive component, which is determined by flow into resistance, becomes 0. So the major proximal airway pressure will be equal to the elastic component, which is equivalent to the plateau pressure. Now, peak pressure versus the plateau pressure. Peak pressure, as we have seen, is the result of resistive component plus the elastic component, and the plateau pressure is the result of the elastic component. So whatever factors which changes the elastic component affects both the plateau pressure and the peak pressure, but the factors which affects the like peak pressure, like secretions, biting of endotracheal tube, bronchoconstriction, does not affect the plateau pressure. Now, the peak pressure is a maximum proximal airway pressure during the respiratory cycle, whereas the plateau pressure is a maximum alveolar pressure during the respiratory cycle. Peak pressure is indicative of resistive component, elastic component, or both. It can rise due to causes which increases the resistive component, like biting of endotracheal tube, secretion, bronchoconstrictions, as well as factors which increases the plateau pressure, like pulmonary edema, fibrosis, ascites, obesity, pregnancy, also increases the peak pressure. At the same time, these factors increases the plateau pressure as well. Now, the peak pressure decreases with inspiratory effort and endotracheal tube cough leak. Now, this is the elevated peak pressure. First figure is the elevated peak pressure due to raised resistive component, and the second figure is the elevated peak pressure due to raised elastic component. Now, ventilator induced lung injury. Now, usually this type of injuries occurs in the friable lungs, like in ARDS. The injury are of 4 types, basically: barotrauma, volutrauma, atelectrauma, and biotrauma. Biotrauma is due to the inflammatory mediators. Barotrauma, plateau pressure is the highest alveolar pressure during the entire respiratory cycle. So the target blood pressure should be less than 30 mmHg, helps in prevention of the barotrauma. Barotrauma can lead to pneumothorax, pneumomediastinum, and subcutaneous emphysema. Volutrauma, high tidal volume leads to increased lung parenchyma stretch, which leads to further lung injury and inflammation. So the target should be tidal volume should be less than 6 ml per kg of ideal body weight in ERDS, and it has shown a better survival in multi-center randomized control trials. Ideal body weight is used for tidal volume, as lung correlate better with the height rather than the weight of the patient, as adult lungs do not grow with the weight gain. So the ideal body weight should be used for the tidal volume setting. In pressure control ventilation, tidal volume should be closely monitored, as you have seen earlier. Atelectrauma is due to the repeated opening and closing of the alveoli. It is due to the shear stresses generated at the interface of the collapsed and aerated alveoli. Because of loss of surfactant in ARDS, it leads to the alveolar collapse. So the target should be setting the PEEP above the closing pressure of the alveoli, that is above the lower inflection point. Will prevent the open alveoli from closing and hence reduces the atelectrauma. Psi, which is an intermittent high tidal volume, can be used to open the closed alveoli, and PEEP can be used to maintain these open alveoli open. Now, this is the pressure volume loop of an ideal pressure volume loop. You can see there is a lower inflection point, which is the minimum pressure required for alveolar recruitment, and there is a higher upper inflection point, above which there will be the regional over distension of the alveoli. So the target PEEP should be more than the lower inflection point, between lower inflection point and the upper inflection point. Now, this figure shows the alveolar pressure at state of the alveoli at different alveolar pressure. You can see at B, D, and F, the alveolar pressure is the same, but the alveoli is open at D and it is closed at B and F state. This shows the importance of the opening and the closing pressure. Now this is the figure shows how the PEEP can be beneficial and how it can be deleterious. In the first figure there is no PEEP, so the entire tidal volume goes into the aerated alveoli, and which increases the plateau pressure, and this leads to the capillary compression and hypoxemia. At the same time there will be shunting of the non-aerated alveoli. In the second figure you can see there is the optimal PEEP, so the tidal volume gets distributed in both the alveoli, which decreases the plateau pressure and helps in better oxygenation. Now in the third figure, because the PEEP has not able to open the alveoli, so the entire tidal volume goes into the single alveoli, and this leads to very high plateau pressure, causing the capillary compression. At the same time, in a non-aerated alveoli there will be shunting of the blood, so it causes hypoxemia. So the PEEP should be titrated very carefully. Now permissive hypercapnia, this is commonly used during the ERDS lungs. The increased CO2 due to reduced alveolar ventilation because of low tidal volume ventilation is permitted because of known beneficial effects of low tidal volume ventilation in ERDS. However, this may lead to the patient discomfort and patient ventilator desynchrony. This, and hence you may require more sedation and even paralysis. Now, how the mechanical ventilation is affected during obstructive lung disease? You encounter mainly three problems: breath taking, gas trapping, and auto PEEP. Breath taking is triggering another breath before the complete exhalation of the previous breath, which leads to gas trapping. Some air remains in the alveoli at the end of the exhalation, and this further leads to the auto PEEP, which is an increased air at the end of the expiration, a phenomenon known as auto PEEP. Now this is the normal airways, and this is the increased airway resistance. In normal airway resistance, you can see at the end of expiration the alveolar pressure equalizes to proximal airway pressure, and in patients with increased airway resistance like COPD, asthma, at the end of the expiration the alveolar pressure still is above the proximal airway pressure, this leading to a auto PEEP and gas trapping. This auto PEEP and gas trapping can lead to the barotrauma, decreased venous return, and obstructive shock. Now expiratory pause maneuver, as we have seen, inspiratory pause maneuver was used to identify the plateau pressure. Expiratory pause maneuver can be used to know the auto PEEP. Now this figure shows how increasing the expiratory time will help in patients with expiratory flow limitation and avoiding the auto PEEP. Now ventilatory strategies for obstructive lung disease. Basically you have to increase the expiratory time, or reduce the inspiratory time or respiratory rate. Now the patient ventilator desynchrony. If the patient on mechanical ventilation has started breathing of its own, then you may face with this problem of desynchrony. If the clinical condition allows for sedation and paralysis, then desynchrony can be avoided. However, in all the clinical conditions, patient can't be sedated and relaxed and can't paralyzed in all the clinical conditions. So you may face with this desynchrony. Now desynchrony can be divided into three types: trigger related desynchrony, target related desynchrony, and cycle related desynchrony. Trigger related desynchrony are mostly of two types: ineffective triggering, where the patient attempts the breath but is not delivered; extra triggering, where patient does not attempt the breath but still the breath is delivered by the ventilator. Target related desynchrony is due to inadequate flow delivery or excess flow delivery, and cycle related desynchrony are of two types: double triggering and delayed cycling. Ineffective triggering occurs due to weak inspiratory effort of the patient. Triggering threshold when set too high, making the ventilator less sensitive, or use of continuous flow nebulizer with flow trigger, or auto PEEP in patients with expiratory flow limitation in COPD and asthma patient. Now troubleshooting, how will you troubleshoot the ineffective triggering? You can have an adequate reversal of the muscle relaxation. You can, if you are using a flow nebulizer, then better use a pressure trigger rather than using flow trigger. Now treating the in COPD and asthma patient, you can treat the increased airway resistance by bronchodilators and corticosteroids, or if there is auto PEEP, then you can add extrinsic PEEP. Extrinsic PEEP helps in nullifying the effect of the auto PEEP. You can see with auto PEEP there is a increased requirement for pleural pressure to become more negative, to make the ventilator sense for the breath. So by adding the auto PEEP, you can help in nullifying by adding the extrinsic PEEP, you can help in nullifying the effect of auto PEEP. This is a flow nebulizer. you can see there is a continuous flow of gas from inspirator to the expiratory limb. Now if you set the flow trigger, then the patient has to suck in all the flow delivered by the nebulizer plus the flow trigger gas. So better to set a pressure trigger when you are giving a flow nebulizer to the patient. Now extra triggering occurs when there is excessive condensation of the in circuit resulting in water oscillations, there is a small leaks in the circuit, or there are some cardiac oscillations. You can troubleshoot this by setting the trigger threshold to a higher level. So optimal trigger is low enough so that the patient can trigger every breath with minimal effort, but high enough to avoid the auto triggering. Target related desynchrony. Target related desynchrony is of two types, due to inadequate flow or due to excess flow. You can solve this problem by adjusting the flow rate or by increasing the sedation or agitation, or controlling the agitation or the pain. Now cycle related desynchrony is of two types, premature cycling and delayed cycling. Premature cycling occurs when the neural T-inspiratory time, that is the inspiratory time of the patient's central nervous system, is more than the ventilatory inspiratory time. This results in double triggering. And delayed cycling occurs when there is a neural T-inspiratory time is less than the ventilator T-inspiratory time. Here the patient's expiratory muscle starts exhalation when the ventilator is still delivering the tidal volume. You can solve the premature cycling by decreasing the flow rate or increasing the tidal volume in volume control ventilation, and in pressure control ventilation you can increase directly the T-inspiratory time when there is a premature cycling. And when there is a delayed cycling in volume control ventilation, you can set the T-inspiratory time accordingly. Indications for mechanical ventilation. These are 6 main indications: increased work of breathing, increased demand for ventilation, neuromuscular weakness, alveolar hyperventilation, hypoxemia, and airway protection. For airway protection, increased work of breathing, first indication. Mechanical ventilation reduces the work of breathing by providing the driving force for inspiration, and work of breathing can increase due to increased airway resistance as in COPD, asthma, laryngeal edema, or increased stiffness of the lungs as in pulmonary edema, pulmonary infection, pulmonary hemorrhage, fibrosis, increased stiffness of the chest wall as in kyphoscoliosis, and abdominal distension conditions like pregnancy, ascites, and obesity. This all condition increases the work of breathing. Now driving pressure is the difference between the plateau pressure in the PEEP, and as we all know, it is a very strong predictor for mortality in ARDS. So ventilator assumes the work of breathing by increasing the proximal airway pressure, and patient assumes the work of breathing by decreasing the alveolar pressure. Now increased demand for ventilation occurs in following conditions, and all these conditions may need a mechanical ventilation, like severe metabolic acidosis. In patients of COPD or compromised respiratory compromised patient, they may not able to compensate for this acidemia, and they may need a mechanical ventilation. Increased dead space ventilation as in pulmonary embolism, or patient with severe circulatory shock. Now at rest, normally 5% of the cardiac output goes to the respiratory muscles, but during shock the respiratory muscles may consume up to 20% of the cardiac output to increase the O2 delivery. Now with mechanical ventilation, you can unload these respiratory muscles and direct the major part of cardiac output towards the vital organs like heart, brain, and kidney, and you can save these vital organs. Neuromuscular weakness conditions like Guillain-Barré syndrome, myasthenia gravis, amyotrophic lateral sclerosis. And in alveolar hyperventilation conditions, these conditions can be divided into two groups mainly: want breath condition and can't breath conditions. Want breath conditions are the conditions in which there is a decrease of respiratory drive of the patient, as a patient's as in drug induced sedation, CNS disorders, or the circulatory shock or metabolic encephalopathy. Can't breath conditions in which there is an increased work of breathing or there is a neuromuscular weakness. Mechanical ventilation helps the want breath conditions by triggering the breath for adequate ventilation, and helps the can't breath condition by decreasing the work of breathing. In conditions with hypoxemia, as in alveolar hyperventilation, low partial pressure of inspired oxygen, ventilator perfusion mismatch, shunt, or diffusion abnormality. Now the weaning from ventilator. Now before starting the weaning, you have to assess the readiness of the patient to wean. Now this readiness is to be done before starting the weaning. Now there has to be some significant improvement of the initial cause of the respiratory failure. There has to be adequate oxygenation with minimal FiO2 and PEEP, like SpO2 of more than 90% with FiO2 of less than 40% and PEEP of less than 80. Ability of the patient to initiate the breath spontaneously, and other parameters like mental status, cough strength, secretions, respiratory demand and cardiovascular status. All these to be assessed before starting the weaning. Now weaning can be done by giving a spontaneous breathing trials. Now spontaneous breathing trials are mostly are of two types, TP's trial and a pressure support ventilation. The aim of giving the spontaneous breathing trial is to simulate a post-extubation condition and to assess whether the patient has adequate muscle strength and stamina to meet the oxygenation and ventilation need without the assistance of the mechanical ventilator. The spontaneous breathing trial should be at least of 30 minutes and should not be more than of 120 minutes. Now we will see TP's trial. In TP's trial, the endotracheal tube remains but the positive pressure is removed. A T-shaped adapter is connected to the endotracheal tube through which a supplemental humidified oxygen is given and the clinical and hemodynamic parameters are observed. If you have any sign of impending respiratory failure, then the trial is terminated. This avoids the need for re-intubation because the endotracheal tube is still in the patient. It better stimulates the post-extubation respiratory and cardiac workload than the pressure support ventilation. However, the only limitation is the endotracheal tube may increase the work of breathing and can underestimate the readiness for weaning. However, TP's trial serves a better than pressure support ventilation for patient with LV failure and LV compromised patient. Now pressure support mode of spontaneous breathing trial. It is, as we all know, all breaths are pressure trigger in this. You have to set the pressure support to a very low level of 5 cm of H2O. If patient can generate enough tidal volume with this low pressure support, then it indicates the readiness for extubation. However, if the patient has rapid shallow breathing, then it is likely that extubation will not be tolerated. Now these are the clinical signs which you have to observe by weaning the patient while giving the spontaneous breathing trial, either TPs or pressure support. That is accessory muscle use, paradoxical ribcage and abdominal movement, intercostal retraction, nasal flaring, profuse diuresis and agitation. Now lastly, the hemodynamic effects of the mechanical ventilation. Mechanical ventilation affects the cardiopulmonary system in 4 main ways: oxygen delivery, intrathoracic pressure changes, preload and afterload. The amount of oxygen delivered to the body is the product of the cardiac output and arterial oxygen contained. Now decrease O2 delivery can be due to either decrease in cardiac output or as in cardiogenic shock and hypovolemic shock, or due to decrease in arterial content of the oxygen. Mechanical ventilation affects both the aspects of O2 delivery, that is the cardiac output, as you will see further, and arterial oxygen content by affecting the partial pressure of oxygen in the blood. Now intrathoracic pressure. Positive pressure ventilation increases the airway pressures. This in turn is transmitted to the pleural space. The degree to which the airway pressure is transmitted to the pleural space depends on the lung compliance. So the patients with higher lung compliance, as the patients with emphysema, the transmission of the airway pressure to the pleural space is more than the patients with stiff lungs. So the patient with higher lung compliance will have more changes in the hemodynamics with mechanical ventilation than the patients with stiff lungs. Increased airway pressures leads to the compression of the cardiac structures and intrathoracic blood vessels. Preload. Frank-Starling curve determines the relationship between the preload and the stroke volume. According to the Frank-Starling curve, you can divide the patient into preload sensitive patients and preload insensitive patients. At the patients with preload sensitive part, a small increase, a small changes in the preload will affect the stroke volume, while patients with preload insensitive part will not have much change in stroke volume with changes in the preload. So with increase in intrathoracic pressure due to mechanical ventilation, there is an increase in right heart pressure. This leads to decrease of venous return. This decreases the RV preload and thus decreases the RV cardiac output, and which decreases the RV preload and decrease in RV left ventricular cardiac output. Now how the mechanical ventilation will affect the afterload. Now afterload is defined as a ventricular wall stress during the systole. Wall stress creates a transmural pressure, which is the difference between the intraventricular pressure and the pericardial pressure. Now increased intrathoracic pressure is transmitted to the pericardial space, leading to increased pericardial pressure. Now with mechanical ventilation, left ventricle requires lesser transmural pressure to achieve the same ventricular pressure, thus reducing the afterload. In simple terms, pericardial pressure can be viewed as a squeezing the left ventricle. Left ventricle, so the mechanical ventilation decreases the afterload of the left ventricle, but in right ventricle the situation is a bit different. Mechanical ventilation may increase the afterload by increasing the alveolar pressure, and we will see further, by causing the compression of the pulmonary capillaries. Left ventricular failure. Now, positive pressure ventilation decreases the helps the left ventricular failure patient in three main ways: by decreasing the preload, by decreasing the afterload, and by decreasing the transmission of fluids into the alveoli by increasing the alveolar pressure. Now, these mostly LV failure patients are in preload insensitive parts. So, by without much reduction in cardiac output, because of the decrease, the mechanical ventilation decreases the preload by increasing the intrathoracic pressure without much reduction of cardiac output, as these patients are mostly in preload insensitive part of the Frank-Starling curve. Hence, a TB trial better stimulates the post-extubation cardiac loading conditions in LV failure patients. Now, in right ventricular failure, the afterload of the right ventricle is the pulmonary vascular resistance, and pulmonary vascular resistance is least at the FRC. As we move away from the FRC, the pulmonary vascular resistance increases. Now, these are the waste zones of the lungs. The PVR is highest in zone 1 and it is lowest in the zone 3. So, what the mechanical ventilation does? Mechanical ventilation shifts the patients in zone 3 and 2 towards zone 2 and 1 by increasing the alveolar pressure. Hence may increase the PVR. But however, if you are balancing the tidal volume and PEEP, then you can have a balance between the PVR and the positive effects of the mechanical ventilation. As you can see here, with collapsed alveoli, alveolar vessels are seen as a red, and extra alveolar vessels is seen as a black dots. Alveolar vessels collapses with the lung expansion and expands with atelectasis, whereas the extra alveolar vessels collapses with the atelectasis and expands with the lung expansion. So, as the lung expands above the FRC, the rising resistance of the alveolar vessels outweighs the falling resistance of the extra alveolar vessels, and hence increases the PVR. So, initiation of the positive pressure ventilation with RV dysfunction can precipitate acute RV failure and refractory stroke. However, this can be prevented by carefully balancing the tidal volume and the PEEP for hypoxemia and acidemia. By giving the mechanical ventilation increases the transpulmonary pressure, which increases the PVR, which increases the afterload, and this decreases the LV stroke volume. And through ventricular interdependence, the LV preload, LV ejection fraction, LV stroke volume, and cardiac output also decreases, and this leads to the hypotension. So, you have to balance very carefully in RV failure patients. Thank you.